and welcome back to EASD TV. Now, one of the most intriguing titles in the programme that I spotted was The Evolving Enigma of Type 1. And with me, two people who are presenting at that session to talk to us about it. And I'm delighted to introduce Maria Redondo, who is from Baylor in Texas, but via Spain. And Emily Sims from the Indiana School of Medicine. Delighted to welcome you both. Now, Maria, in the past, I guess, everybody assumed that type 1 was just this single condition, but that's not how we think now, is it?
That's correct. So the classical presentation for type 1 diabetes happens in young children, European ancestry, thin, and then progresses very quickly to complete loss of the ability to make insulin. However, it has been already observed that there are different clinical presentations where even adults can develop type 1 diabetes, and in fact, the numbers of adults who develop type 1 diabetes is likely even larger than that of children. Also, it appears in non-European ancestries, also very frequently, and can even appear in people who have obesity. So right now there's a big interest in discovering all of the different subtypes of type 1 diabetes. Some of those have been called endotypes, and then the interface with type 2 diabetes, how that changes the presentation, so that we can prevent the disease better, treat it better. That's really the goal.
And I guess it's a problem sometimes that type 1 diabetes may not be recognized because the child that is presenting is not the child you assume to be one that's going to get type 1 diabetes.
Absolutely, absolutely. Recognizing type 1 diabetes has always been a challenge because it's not a super common disease, right? Appears in 1 out of 400 people. So symptoms of increased urination, increased thirst, unwanted loss of weight, that always has to lead the physician to test for diabetes with a blood test. That is very important. In addition to that, more and more children are developing type 2 diabetes, and it is sometimes difficult to differentiate which one of those two types people have. In fact, we used to think that children under the age of 6 months do not develop type 1, and it has been shown that they also can. The same in adults. In adults, most people would not think about type 1 diabetes, but it can happen. So I think that one of the goals that we have is bringing awareness about type 1 diabetes that can develop from very, very early until the adult age, and people of all shapes and colors, definitely, yes.
Now, we were hoping that David Leslie was going to be with us, but unfortunately he's sick, but he will, I think, be back in time to be with us for the later part of this Congress. But autoimmune presentations in adults was what he was speaking about. Is there a particular issue there?
I think so. I think in adults it's harder to recognize because type 2 diabetes is much more common than type 1, so it really takes a very astute clinician to recognize that this person really has type 1 diabetes. There are some signs of that, but I think that would be important to really test so that we don't have to wait until it is too late and the person has developed an acute decompensation of the diabetes, such as diabetic ketoacidosis. Also, in adults, type 1 can take different forms. One is very similar to the form that takes in children, where things happen very quickly and the person develops insulin dependence very immediately, right? Almost at the time of the diagnosis. However, sometimes it takes a more subdued way where people develop, lose their ability to make insulin much more slowly, and that is very easy confused with type 2 diabetes.
And that must be very difficult, that people assume, particularly if people are older, that and particularly if they're overweight, that this must be type 2. And
that's exactly
type
right.
1.
And it can lead to acute emergencies such as having DKA, what we call DKA is diabetic ketoacidosis, or just having very poor control of their diabetes for years until it is recognized this person needs insulin.
So Emily, we've got all these different subtypes of diabetes. Diabetes is so much more common now, and I know that screening is your particular interest. So are we ready for universal screening?
Yes, we're definitely ready for universal screening. This is a really kind of very exciting time in our field because over the past few years, we've had a positive trial that showed us that disease modification in type 1 diabetes can actually change the natural history of the disease if you catch people kind of before they have the symptoms of when type 1 diabetes starts. So now we're kind of in a position where we really have the potential to benefit people by identifying them very, very early on in the process. And, traditionally a lot of programs that have screened for very early stage or pre-symptomatic type 1 diabetes have targeted people who are family members of people with type 1 diabetes to kind of try to carve out the people at the highest risk. But we know that 90% of people who present with new type 1 diabetes don't have a family history. So really, if we really want to benefit the most people and kind of target that process, kind of delay the need for insulin, we need to start screening people in the general population.
So when you say screening, of course there are lots of different ways you could do that.
Yeah.
You could do, antibody, you could do neonatal. What we do genetic screening, so panel screening or whole genome sequencing.
Yeah.
So what would be your ideal method?
Yeah.
If Emily ruled the world.
Right. It's a great question, and it's a little hard to answer. So you're right. So there are different ways that people approach it. So some people just do cross-sectional screening for islet autoantibodies, which is great because not only can you screen for risk, but you can diagnose someone with early stage diabetes just based on that testing. A lot of people have also employed an approach where they start with genetic screening to kind of find the people who have the highest genetic risk, and then that allows you to do monitoring for those islet autoantibodies and those highest risk people, maybe not have to test as many people for those islet autoantibodies. So there are pros and cons to both types of screening, and I think really people should just start screening. There are lots of examples of really great programs that have started in Europe and the United States, Australia, lots of different continents. I heard Canada just got funding for general population screening. So I think really we're just going to have to see in different environments which ones of these work best and how they kind of pan out and what the challenges are. And hopefully they'll get incorporated into guidelines so that it's not kind of just part of a research program, but that it applies to everybody.
I mean, part of this is prompted by the new treatments that are now coming on stream. But Maria, there are other things that you could do. I mean, obviously you could just monitor for antibodies, but you could also, for instance, because it's an intervention, but it's not an intervention with a big risk, you could, for instance, ensure that those children with a genetic risk receive vaccination for rotavirus or those other kind of enteroviruses.
Yeah, so it is clear that at least a big subset of people who develop type 1 diabetes really have a rotavirus or enterovirus infection as a trigger or definitely an etiological a cause, right, for the type 1, along with the genetic component that you have alluded to. So I think that, in that case, absolutely, it would be important. I still think that we need to know more. Who are the people who will really benefit from this? A vaccine, obviously, we don't think that has side effects, right? But if we are planning to approach a population program to do that, I think would be really very important to have those data that tells us who particularly is in that right. Also, the immune system is tricky, and sometimes timing is important. And when you do things, at certain point closer to the birth, later on, it could have different responses, and that has been shown with some potential causes, such as a cow's milk or things like that. So I think that knowing more about the specific triggers in each subtype of type 1 diabetes, it would be critical at this point.
But knowing more depends on screening.
Right. I think there's another really big benefit of screening that's been recognized for a while, even before we kind of had a disease-modifying therapy on the table, which is that, a lot of times people present with new diabetes. Frequently they present in DKA, which is a life-threatening critical illness and is associated with short-term morbidity, but also long-term effects on your glycemic control. For kids, there's probably some mild neurocognitive long-term effects of presenting in DKA, and we know that people who get screened, get education, and get monitored have drastically reduced rates of DKA at diagnosis. And so, these individuals, they can get this kind of measured approach to education where, first they learn about what type 1 diabetes is, then maybe they learn about monitoring their blood sugar, and then maybe gradually introduce insulin versus this kind of fire hose of information that gets kind of thrown at people now when they get diagnosed.
When they are critically ill.
Exactly, yeah. So I think there's tons of benefit there, even if you kind of aren't thinking about interventions with disease modification too.
Okay, I'm going to give you both my Vivienne Parry magic wand. And if you ruled the world, what would you be doing? So what would you like to do to help ordinary diabetologists understand more about these different subtypes?
Yeah, so my particular interest is in incorporating genetics into clinical practice and clinical research. I think that we know a lot about the genetics of type 1 diabetes, but now the next step is to really make it usable for the clinicians, so that, for example, we have a study in Houston where we are using genetics as one more piece to differentiate between type 1 and type 2 diabetes in children. Then another important project that we are currently working on is incorporating genetics in the best possible way into the prediction of type 1 diabetes. So that would be what I would like if I had a magic wand.
Right. Wish granted. Tick. Okay. How about you, Emily?
So I'm going to wave my magic wand and really much more effectively communicate with primary care doctors. I think we really need to get this message about pre-symptomatic early stage type 1 diabetes and screening out to these individuals who are really, interfacing with our patients on a much more regular basis. I think that's the only way these kinds of programs are ultimately going to be successful, and it's a really important need for us to do that education.
And Emily, let me just ask you, if I take you forward 5 years, do you think we will be doing universal screening for diabetes?
I think that there will be some countries that are doing it for sure in 5 years. Yeah, I think we're close. I think, and some places already have, a lot of infrastructure set up. In Germany, in Bavaria, they've been doing screening through lots of PCP clinics for a while. There's just a big grant that was funded for multiple countries in Europe. I mean, I think things are really, really progressing really rapidly. Like, get ready for a paradigm shift. It's really, really exciting in our field right now. Yeah.
Fantastic stuff, both of you. So you had it there first on EASD TV, a paradigm shift in screening for type 1 diabetes. There's so much more to come. Back with you soon.